Assalamualaikum, Puan Asma. I am Muhammad Khairul bin Romli. Today I would like to present my case study report. For my case study, the aim is to investigate systemic lupus erythematosus (SLE) in patients who suffered from joint pain. For the introduction, this is a 26-year-old who presented with joint pain. She was recently diagnosed with seropositive rheumatoid arthritis. Based on the clinical presentation, erythrocyte sedimentation rate (ESR) of 54 mm per hour and positive serologies for rheumatoid factor (RF) and anti-cyclic citrullinate peptide (CCP), her disease activity score DAS28 was 5.1, which indicate moderate disease activity of rheumatoid arthritis (RA). She was treated with 2.5 mg of methotrexate weekly. However, her joint pain symptom persisted and showed poor response to treatment. The treating physician requested for anti-nuclear antibody (ANA) test to look for the possibility of concurrent other autoimmune diseases. The overview of the illness or condition. The patient had persistent joint pain although she had been treated for RA. Hence, the treating physician collected blood sample and ordered for anti-nuclear antibody ANA test to assess the possibility of other autoimmune diseases. Patients with RA and SLE can present with joint pain. Positive RF and anti-CCP is commonly found in patients with RA. It is responsible to activate complement system that trigger the joint inflammation by promoting angiogenesis, the new blood vessels, and stimulating inflammatory cells around the joints. This process will eventually causing joint inflammation and damage. For the pathophysiology of inflammation in SLE patient, in patients with SLE, joint inflammation occurs by the activation of the complement system that is triggered by the immune complexes of ANA and nuclear antigen. Nuclear antigen is the product of cell apoptosis from various factors such as ultraviolet, sexual hormone, virus, and bacterial infection, and medication such as hydrazine and isoniazid. Because of human body is not able to recognize the nuclear antigen remnants, hence it produces autoantibody, which is ANA. For the treatment for SLE patient, the mainstay treatment for SLE includes anti-inflammatory drugs, for example, steroid therapy, that is responsible to reduce inflammation. The other is hydrochloroquine. Is also the first line treatment and it helps to reduce disease flare rate, protect organs, and control joint pain and inflammation. The flare of SLE could be defined by the worsening of the condition or an increase in its symptoms. Outcomes of the laboratory investigation. Anti-nuclear antibody (ANA). ANA testing is used to investigate patients suspecting autoimmune diseases such as SLE, Sjogren's disease syndrome, and scleroderma by detecting the presence of ANA in patient's serum. The patient's serum is extracted in a plain tube with spiriting gel. Bioflash analyzer is used with enzyme-linked immunosorbent assay ELISA technique to interpret the result. In this patient, she had positive ANA with value of more than 200 CU. The reference range for ANA is equal or less than 19.9 CU. ANA immunofluorescence (IF). The patient's serum was also tested for ANA using immunofluorescence method. The test was done using the fluorescent microscope. She had positive result of homogeneous and speckled pattern with very high titer of more than 1:1000. The homogeneous pattern of immunofluorescent autoantibody on HEP2 cells commonly associated with SLE and drug-induced lupus. The speckled pattern could be present in patients with SLE, Sjogren's syndrome, mixed connective tissue disease, MCTD, scleroderma, and myositis. The right picture shows the fluorescent microscope used for ANA-IF procedure. These two pictures show the homogeneous pattern and speckled pattern could be examined under fluorescent microscope. For the left picture shows the homogeneous pattern, the interface cells with uniform diffuse nuclear staining and metaphase cells with chromosome demonstrated solid fluorescence, while the right figure shows the speckled pattern. Interface cells demonstrate speckled nuclear staining. The negative staining is represented by the dark region. Anti-double-stranded DNA, dsDNA antibody. Anti-double-stranded dsDNA antibody was also tested in this patient to confirm the diagnosis of SLE and rule out other types of autoimmune diseases. Anti-dsDNA testing is also used using the bioflash analyzer chemiluminescence immunoassay CLIA method. However, the patient's result was negative with concentration of 12.4 international unit per milliliter. This could suggest that the patient may have SLE or other autoimmune diseases such as RA, Sjogren's syndrome, MCTD, or scleroderma. The standard reference of anti-dsDNA is as follows. For the negative is less than 27 international unit per milliliter. For indeterminate, 27 until 35 international unit per milliliter, and for the positive, more than 35 international unit per milliliter. For the opportunity for discussion, the diagnosis of autoimmune diseases such as rheumatoid arthritis and SLE require detailed history and clinical examination. The laboratory test is supportive measures to narrow down the investigations and confirm the diagnosis. This patient may have seropositive RA alone or overlapping syndrome with SLE or other autoimmune disease. She would require further testing, including extractable nuclear antigen (ENA) to further confirm the diagnosis. With that, thank you.